I'll hand over the session to both the chairperson to introduce the speakers and start the proceedings.
Start with the first talk. The speaker for the talk is Dr. Pawan Gupta, and we will be speaking upon the allogenic mesenchymal stem cell therapy in osteoarthritis, recent evidence from India. Dr. Pawan Gupta is President of Medical and Regulatory Affairs at Therapeutics Research, Bangalore. So I invite Dr. Pawan on the stage.
Help for treatment for osteoarthritis, which is allogenic mesenchymal stromal cells therapy in osteoarthritis. What is the recent evidence from our country? This is a first-in-class allogenic mesenchymal stromal cell therapy for osteoarthritis, providing prolonged efficacy and maintains the cartilage integrity. It is a single intra-articular injection. We have a strong phase 2 and phase 3 clinical trial data in India with around 200 plus patients, where we have seen that with a single intra-articular injection, there is at least 1 year relief of pain, there is a decrease in stiffness and improvement in the physical function, and it maintains the cartilage quality for 1 year. And it has got minimal side effects. The whole process is made in India, starting from in vitro studies, preclinical studies, and different phases of clinical trial. And it is approved by the Office of GCGI for grade 2 and grade 3 osteoarthritis of the knee joint. Why MSCs are used for stem cell therapy? Because of the inherent properties of these cells. These cells are immune privileged, that means they express low level of MSC class 1. They lack MSC class 2, and most important thing, they lack the post-immunity molecules CD40, 18, 86, so they will not be able to stimulate the allo T cells. And they also express strong IDO or indolin 2,3 dioxygenase on induction. That means once increased amount of IDO is expressed, they have immunomodulatory properties and they have anti-inflammatory properties. Because of these reasons, MSC are used for the stem cell therapy in osteoarthritis. So what is the possible mechanism of action of these cells in osteoarthritis? The first step is to control the inflammation. And once the inflammation is controlled, it will allow the chondrogenesis process to start. So once the cultured cells are injected into the joint, the first step is by liberation of anti-inflammatory factors, PGE2, which controls the inflammation by the inhibition of the T cells for liberation of inflammatory cytokines like TNF-alpha amongst others. Then once inflammation is controlled, we have got the secretion of chondrogenic factors like thrombospondin 2 or TSP2 and HGF or hepatocyte growth factor, which stimulates the resident chondroprogenitor with formation of the chondrocytes or hyaline cartilage. And lastly also, it does inhibits the MMPs 2 and 9, and causes the cartilage ECM destruction, and stops the formation of the cartilage ECM destruction. So with this multimodal action of these cells, the ultimate result is formation of cartilage, and that is of hyaline cartilage. And this we have seen that also in our preclinical studies, where we have induced the rat model by injecting monoiodinoacetate, which causes apoptosis of the cartilage. And what we have done is that we have injected high dose, which is seen by the pink line, and plus the low dose, which is seen by the green line. And you can see that there is a significant improvement in pain scores from week 2 onwards, both in the high dose and low dose as compared to the HA control, which is the yellow line, and the disease control, which is the red line. And this significance is maintained from week 2 to week 8 after injection. The second important thing is that we have stained the joint for proteoglycans staining by saffron staining, and we have seen that both in high dose and in the low dose, which can be seen here, that at 12 weeks of follow-up, they all stain positive for proteoglycans as compared to HA control and the disease control, which can be seen here. Actually, they were negative for the cartilage. So it means that by single intra-articular injection, there is relief of pain, and there is a regeneration of hyaline cartilage. So based on this data, we have gone ahead with the phase 3 trial after completion of safety study, phase 1 trial and phase 2 trial. And the product is off-the-shelf adult human bone marrow derived cultured pooled allogenic mesenchymal stromal cells This is a randomized double-blind placebo-controlled study, and 146 patients randomized equally in cell and placebo arm, 73 patients in each arm, and the cell arm received 25 million cells in 2 ml of 2 ml of solution, followed by 2 ml of HA. And the placebo arm received 2 ml of placebo followed by 2 ml of HA, single intra-articular injection under ultrasonic guidance. The follow-up is for 2 years. The primary endpoint is WOMAC composite index score as compared to the placebo arm, and the secondary endpoint was WOMAC subscores, which is pain, stiffness, and physical function. The VAS scores and the MRI imaging done at 4 time points: baseline, 6 months, 12 months, and 24 months, to assess the cartilage quality by T2 mapping, cartilage volume, and cartilage thickness. And what has been published is there is minimum improvement by 20% between the treatment group, that is between the cell arm and placebo arm of the WOMAC scores, then it is a measure of effectiveness. So we have included patients between 40 to 65 years with BMI less than 30 kg per meter square, all cases of primary osteoarthritis, in grade 2 and grade 3 as defined by the Calgren laws for radiographic criteria, and we have excluded patients who have received intra-articular steroids or HA within the last 3 months, arthroscopy of the study joined in the previous 12 months, any history of surgery or major trauma, patient having gross deformity, any varus deformity or flexion deformity more than 10, if it is more than 10 degrees, and plus we have excluded patient having exclusive patellofemoral arthritis, bilateral subcondylar sclerosis, complete ACL, PCL tear, and grade 3 root tear or complete root tear or bucket handle tear of the meniscus. So this is actually the glass shipper in which the cells will be shipped at -185 to -196 degrees centigrade, and plus in this it will contain one cryo vial containing 25 million cells in 1 ml of Cryostore CS5, which is a cryopreservative mixture containing DMS of 5%. And once the vial is being taken out from the cryoshiper, it has to be thawed at 37 degrees centigrade, and then mixed with 1 ml of Galvan, known as plasma light A, and this total volume of 2 ml is given by intra-articular injection, followed by 2 ml of HA. So total volume given administered is 4 ml under ultrasound guidance. So the role of HA is at twofold. First, it acts as a scaffold, helps in homing of the cells, and second is prevent fibroblast invasion and formation of the fibrocartilage. So this is the primary endpoint, which is the WOMAC composite index score. The blue line is of the placebo arm, and red line is of the cell arm. What interestingly we saw that once actually we inject the cells, both the cell and placebo arm, the WOMAC composite score decreases till 3 months follow-up. This is maybe because of effect of HA. And once the effect of HA wanes off after 3 months, you can see that for the placebo arm, the WOMAC composite score comes back to baseline at 12 months follow-up. Whereas if you see the red line, the WOMAC composite score continuously keeps on decreasing till 12 months follow-up, and the difference between the two arms is statistically significant, both at 6 months and 12 months, with a p-value less than 0.0001. Now coming to the percentage change, what we have seen is that at 6 months, the difference between the cell and placebo arm with cell decreasing, with cell improvement by 23%, which can be seen by the red bar, and which increases to 46% at 1 year follow-up. And the difference is statistically significant. Most important, 89% of the patient improved with improvement more than 20% at 1 year follow-up, which is clinically significant. Now actually we look at whether grade 2 and grade 3 osteoarthritis had any difference or not, and we saw that both grade 2 and grade 3 osteoarthritis had a similar effect, and so so grade of OA has no effect on WOMAC composite index score, so it is equally effective in both grade 2 and grade 3 osteoarthritis of the knee joint. Now coming to the WOMAC subscores, pain, stiffness, and WOMAC physical function, we saw a similar effect. And there was a decrease at 1 year follow-up with more than 45% in all the parameters, and which was statistically significant. In fact, if you look at the WOMAC stiffness and the physical function at 1 year follow-up, it increased in the placebo arm as compared to the cell arm. And plus again, 89% of the patient improved more than 20% in all the WOMAC subscores. The VAS scores also had a similar analysis in which we saw that after around 3 months of follow-up, the cell arm continuously keeps on decreasing, which can be seen by the red line, whereas the placebo arm, it actually increased and it reached the baseline. And the percentage change, there were more than 40% improvement in the cell arm at 1 year follow-up. So what are the treatment emergent adverse events? The treatment emergent adverse events which were seen were basically injection site joint pain, injection site joint swelling, which was most commonly seen in these patients in approximately 2 to 3% of the patients, which improved by symptomatic treatment. Now we have got the data for 24 months follow-up, and we have seen that if you can see actually the red line, the WOMAC composite score keeps on decreasing till 24 months follow-up, which can be seen here. And whereas in case of placebo arm, it keeps on increasing, it is much higher compared to the baseline, and which is also statistically significant. And the same thing can be seen for the WOMAC subscores, pain, stiffness, physical function, and VAS scores. All are improving in the cell arm as compared to the placebo arm, and difference is statistically significant. It means that by giving a single intraarticular injection, the effect is maintained till a minimum duration for 2 years. Then we look at the most important finding, which is the MRI, which is the T2 mapping. We did measure the T2 relaxation time, which shows us the water content, the hydration, and the collagen network. What we have seen, which can be seen by actually the blue line, which is the placebo, there is an increase in the T2 relaxation time over the span of 1 year, and this difference is statistically significant as compared to cell arm, where the T2 relaxation time is maintained. So it means that the poor cartilage quality is seen by T2 mapping in deep cartilage in the medial femoral tibial compartment, which is most commonly involved in osteoarthritis with placebo arm, and cartilage quality is maintained in the cell arm over a period of 1 year follow-up. This is a slide for a picture of a cartilage volume, where actually you can see that there is an increase in the cartilage volume in the cell arm as compared to the baseline, and this is seen in majority of the patient in the study. This is an important biomarker, which is CTX2. CTX2 is a fragment of the C-terminal cross-linked telepeptide of type 2 collagen, and which is released into the circulation upon the degradation of the cartilage and subsequently secreted into the urine, and is indicative of disease progression. What we have seen is that over a span of 12 months, which can be seen by the red bars, that there is a decrease in the CTX2 values in the cell arm by 7.79 units as compared to the placebo arm, which is continuously increasing. So it means that once the cells are injected, there is a decrease in the progression of the disease. So to summarize my talk, allogenic LSCs has shown to be safe and effective in grade 2 and grade 3 osteoarthritis. Safety has been established in phase 1, phase 2, and phase 3 trial. And efficacy has been established in a phase 3 trial where shown WOMAC composite index, which is the primary endpoint, is decreased by more than 46%. And WOMAC subscore, which is pain, stiffness, physical function, improved by more than 45% in all the cell arm patients. And plus there is improvement in the VAS score by more than 41%. Cartilage quality is maintained by T2 mapping, and improvement in the pro-inflammatory marker, which is HRCRP, and anti-inflammatory marker IL-10. I have not shown the data. And CTX2 in the urine in the cell therapy arm. So with this, we got the approval for allogenic MSC product is approved by DCGI for grade 2 and grade 3 osteoarthritis in non-obese patients with BMI less than 30 kg per meter square. These are the publications which we have published, and for the phase 3 trial, we have submitted our data for publication in American Journal of Sports Medicine. This is a product allogenic off-the-shelf pooled bone marrow-derived mesenchymal stromal cells for grade 2 and grade 3 osteoarthritis. This has been developed by a company called Stempeutics, which is a part of the Manipal group, and it has been sold in the country under the trade name of Stem1 and marketed actually by Iracon. The product is based on the patented Stempeutics cell technology, and we have the patent in 18 countries across the world. So this is a small video of how active cells are being shipped. This is actually a glass shipper in which the cells are being shipped under -196 to -185 degrees centigrade, and you can see the temperature is -196 degrees centigrade. By wearing actually these tire gloves, we can see the fumes of the liquid nitrogen gas. The cassette holder is being taken out, And this cassette holder contains a cryo box, which contains one cryo vial, which is being used, which contains the cells. And this is the liquid that from this cryo box. It has to be thawed in a preheated water bath at 37 degrees centigrade. And this takes around 3 to 4 minutes for thawing the vial. And once this vial is thawed, we have to mix with 1 ml of plasma light A, making the total volume to 2 ml. You can see we are aspirating 1 ml of plasma light A from plasma light A bag. And this will be injected into this vial, which contains 1 ml containing 25 million cells. And thus this has to be injected into the joint, followed by actually 2 ml of the etching. If any, yeah, that's all I have at this moment. Thank you.
I hope there will be a lot of questions. Please, Understand, please.
Can you use corticosteroids along with this? It's a common practice when you are injecting hyaluronic acid. Some of the people would have an allergic reaction no matter what product you use. And many of us would use a corticosteroid along with it. What about this? And the second is, I was intrigued by the fact that you are recommending ultrasound guidance for injecting the knee. Now, most of the...
But we are not injected intra-articular injection by for using the corticosteroids. So we don't recommend the corticosteroids should be used, because we don't know if the corticosteroids are used along with the cells, the viability of the cells will be compromised. So we don't recommend that it should be used along with the cells in the same manner as intra-articular injection at the same time. Now for the second question.
ultrasound guidance.
Yeah, for actually ultrasound guidance, we have the recommended ultrasound guidance. It depends upon the clinician whether he wants to do ultrasound guidance or can be done by a blind procedure. It depends upon the clinicians.
No, but you've recommended that, and it puts us in a catch-22. If the results are not good, he'll not come and ask the STEM Putex that my results are not good. He's going to say, is it because it was not using ultrasound? But this kind of a restricted labeling makes it, and it's a practical question, and let me ask people, how many inject the knee using ultrasound?
No one.
So, one or two. Routinely, all patients with ultrasound?
No.
So the vast majority of people are not using ultrasound to inject the knee, and if you have this labeling and the results are not good and it's an expensive product, the patient is going to not ask the company but he'll ask the doctor.
So for our phase 2 trial, which we have done in 60 patients with dose finding study, we have not used the ultrasound guidance for giving the cells. But as per the recommendation of the regulatory authorities in the phase 3 trial, by force we had to use an ultrasound guidance method. And what we have written in our label that ultrasound guidance, it is preferably it can be used. Depends upon the doctor what he wants to do. We are not forcing that it should be ultrasound guidance or not.
Yeah, we have a lot of time. You can ask.
With the ICMR and DBT, and I was the principal investigator. So I know that was, and we used to have all this thing. We imported the kit from that time from Thailand. Probably it was made in Korea, and it was not effective. I must warn you that we did about 20, I don't know, there must be more, probably the research has been done. I joined a little late, but this project was done, we did about long back, about 20 years when the stem cell came. So over a period of time, probably things have changed, and it's a welcome that at least something is there. Now, why ultrasound guided, you said that probably be about 10 to 20% injections, especially in osteoarthritis. It probably may not be going at the correct place, and you want to cover it legally. If you don't put it in correct place, it won't work. So probably that is, otherwise these clinicians are very good to inject without ultrasound.
So to answer your question, sir, because in the armed forces, because I have also worked in the armed forces for 24 years. So what actually they have done in the army hospital Delhi camp is that they have used mononuclear stem cells, which has been aspirated from the bone marrow, and the mononuclear stem cells were used for osteoarthritis, apart from for the actual critical ischemia and cerebral stroke. They have not used the mesenchymal stromal cell, which requires the GMP for facility and setup, where the cells because the cells has to be cultured. So we have not used the mesenchymal stem cell, we have used the mononuclear stem cells. There are a lot of difference between both the cells, and MSCs in the published literature also shows that MSCs are much more effective, and it has got a better convergent properties as compared to mononuclear stem cells. That's the reason MSCs are better in osteoarthritis as compared to the mononuclear stem cells. And plus also for the second point for ultrasound guidance, there has been a publication, there are in fact many publications which says that by giving a blinded intra-articular injection, 95% success is there. But 5% failure is always there when we are using a blinded method. To actually overcome that, we have used and we have been guided to use ultrasound guidance. That's the reason we are recommended that it should be the preferably method of injection of stem cells.
Shanta Gurwal from London. I wanted to know what was the background of the therapy before that trial. What was the background therapy the patients were on? What was the rescue medicine that was given to the patients? And was there any difference in the usage of rescue medicine in the patients who received the active compound versus the placebo?
So actually all the patients which were recruited into the study, they had a history of 6 weeks uses of analgesics. Before actually they were recruited into the study without any injection, HA or corticosteroid for the last 3 months. And plus the rescue medication, what has been recommended is what was there was actually tablet paracetamol, tablet naproxen, and tablet tramadol, which was used as per the protocol. And what we have seen, the rescue medication was given more to the placebo arm than compared to the cell arm.
Thank you for this interesting topic. I'm interested also in this topic. And first of all, I mean, most of the studies that have been done, both for hyaluronic acid and for stem cells, they concentrate mainly showing you results of WOMAC. And WOMAC is just studies the pain. I mean, when hyaluronic acid and stem cells claim that they regenerate the cartilage, there is no real proof of regeneration of the cartilage. Even yourself, you mentioned that the cartilage sort of was preserved. I don't know what this means, whether it stays as it is without going further down. But actual proof that they regenerate the cartilage is not there. I must remind the audience of ACR 2019 recommendations for osteoarthritis management still holds on, saying that MSCs and hyaluronic acid, they cannot make comment on them because they are so non-homogeneous. Their products are so non-homogeneous that real proof cannot be extracted from them. Thank you.
Yeah, thanks a lot for your comments. About the HA and plus the WOMAC, I agree that HA has not been recommended by American Association or Orthopedic Association for osteoarthritis. And in that HA, the data what has been shown and what is published is that they are effective only for a short duration of 3 to maximum 6 months, depending on the molecular weight of HA which has been used. But what we have shown that because once the cells are injected, and we have followed the patient for a long term, and even we have done a phase 2 trial also, which the patients are there, data is there for some of the patient, data is there for 4 to 5 years also. And that actually we have shown that the patients are improving. And plus the WOMAC scores for these patients are improving persistently over a prolonged period of time. And secondly about the comment on the cartilage. We have shown by a non-invasive method that the cartilage for quality is maintained, because by doing an invasive method, by taking a biopsy, the ethics committee has not allowed for using a biopsy invasive method. what indirect evidence we have shown is that by doing the preclinical studies, where we have shown that once the joints are stained by a saffron stain, which shows the positivity of the proteoglycans, which is the direct marker showing that the hyaline cartilage are grown in these animals. That is the indirect evidence. Direct evidence is only by MRI, by seeing the cartilage quality and the cartilage volume.
But never approved in humans.
No, we have never. We have not done the biopsy in humans. It's very difficult to get the approval for invasive method for taking biopsy for all the patients.
I think we'll move on to the next session. We'll have time for the question answer at the end.
Okay.
Yeah, thank you very much.
Dermatologist in Singapore General Hospital. She'll be talking about molecular basis and potential therapeutic targets in osteoarthritis.
I'm really grateful that the organizing committee invited me to this important conference. And my topic today is the molecular basis and therapeutic target for osteoarthritis. There is indeed no argument about the huge burden of osteoarthritis. It is highly prevalent. Years ago, we estimate that it may affect 10% of our population and up to 30 to 40% among the elderly. It is a leading cause of pain and disability worldwide and causing huge loss in productivity and healthcare spending. The worst part about osteoarthritis is that there is no effective treatment. What we have been offering for our patient is no different from what we have been offering in the past 30 years, including weight reduction and exercise. Some of the time we give painkillers, but not everybody can tolerate the painkillers, and we offer surgery for end-stage disease. There is no disease-modifying osteoarthritis drug that has been approved nowadays. The stem of the lack of advancement probably lies in the pathogenesis of osteoarthritis is not clear. Nowadays, we know that it is not just limiting to the cartilage, but affecting the whole joint. At the same time, it is a very complex disease and also very heterogeneous. The structure and the symptoms may not be correlating very well with each other. On the structure side, you will see cartilage damage, meniscus, synovitis, etc. But on the other hand, you have the symptom, pain, and disability. So are we treating the structure modification, or are we treating the condition of illness is something that we need to work on. Perhaps if the pathogenesis is made more clear, there would be a lot more advancement in the therapeutic targets. These are some of the cellular and molecular processes that we understood for osteoarthritis. It turns out that the joint can perceive mechanical signals as damage-associated molecular pattern damp, and these can be from malalignment, past injury, and weight, etc. And these signals are taken up by the pattern recognition receptors in the cartilage and cells, and then trigger the inflammatory pathway, secretion of a lot of cytokines, and then the catabolism of the cartilage and prevention of the anabolism and repair of the cartilage that make the bone remodeling. And all these can be perceived by the neurons and send out a pain signal to the brain. So with this, we can think of some of the ways to block this. The first way is to block the inflammatory pathway. Secondly, what we can do is to block the cartilage matrix. Third is blocking the bone remodeling. And not to forget, we can also block pain pathway to tackle the condition. There might be some differences between the inflammation in osteoarthritis and that of the rheumatoid arthritis. In osteoarthritis, the inflammation is characterized by a lower inflammation, very localized, perhaps in the synovium, and involving the innate immunity. The innate immunity is quite different from what we understand for rheumatoid arthritis involving the T cell and B cell, but in the innate immunity is more involving the macrophages, phagocytes, natural killer cell, mast cells, and antigen-presenting cells. Once again, the innate immunity in osteoarthritis involves sensing the mechanical signals as damage-associated molecular pattern, taken out by the pattern recognition receptor from cells, and these cells involving are macrophages, mast cells, etc., and secrete a lot of cytokines in the synovium compartment, and later on causing damage of the cartilage. So many of these participants are the macrophages, monocytes, dendritic cells, mast cells, etc., and secreting the hormonal response, including interleukin beta 1, interleukin 18, interleukin 6, and TNF alpha. And that's the reason why when we look at one of the old drug, colchicine, we think that it might fit the osteoarthritis pathway because of this clear mechanism of action that can block the innate immunity, including that of the phagocytosis, NAT3 inflammatory pathway, and Casp1 activation, inhibiting the neutrophil recruitment and secretion of interleukin 1, interleukin 8, and also TNF alpha. That's the reason why years back we ran a randomized controlled trial using colchicine to treat symptomatic osteoarthritis in our center. We randomized 109 patients to receive either colchicine or placebo for 16 weeks. However, it was a negative study. We did not see a significant differences in pain and function in patients treated with colchicine as compared to placebo. And in the recent meta-analysis, holding 4 other randomized controlled trials using colchicine, we did not see a favorable response with colchicine as compared to placebo. We were not the only one who failed these challenging games. Other people who use hydroxychloroquine and methotrexate in different kind of osteoarthritis did not show a favorable response. Neither were there much success in the anti-cytokine treatment in osteoarthritis, blocking including interleukin 1 beta or interleukin 1 alpha as well as TNF alpha. But there is one interesting study, the CANTO study, involving interleukin 1 blockage by canakinumab in patients at risk of thrombosis. It's a post-hoc analysis of a randomized controlled trial. After median follow-up of 3.5 years, the investigator find out that there is a reduction in the incidence of TKR and THR with an odd ratio of 0.6. However, it is not the primary outcome to investigate total knee replacement or hip replacement, so further study are required in this area. The second thing we can target is the cartilage matrix. We can do it by blocking the matrix degeneration or stimulating the cartilage regeneration or the Wnt pathway. For cartilage degradation, MMP and Adams 4 and 5 are the most described proteolytic enzyme. And for cartilage regeneration, we can look at carotenogenin, which stimulate the chondrocyte differentiation in mesenchymal stem cells, or some other angioprotein-like proteins, and also the pancrease inhibitors, which sustain the SOX9, which is one of the pathogenesis of osteoarthritis and reconstitute the cartilage. It seems that blocking the cartilage degradation itself is not enough. Perhaps you have to combine with cartilage regeneration strategies. The Wnt pathway in osteoarthritis has been drawing a lot of attention. It has turned out to be an important pathway to maintain the joint homeostasis, including the bone remodeling, synovitis, cartilage degradation, and meniscus degeneration. The Wnt pathway is a tightly regulated cascade intracellularly. So there are many ways to block the Wnt pathway, including inhibiting Wnt secretion, blocking the Wnt binding receptors, or blocking the extracellular activators such as the alspondin, or stabilizing the intracellular complex, and finally inhibit the Wnt gene expression. One of the small molecules called loracivivent is drawing a lot of attention because it is one of the few molecules that has passed through the phase 2 trial and now trying in phase 3 trial for osteoarthritis. The main mechanism of action is mainly through 2 pathways, including the CLK, the CDC-like kinase enzymes, and also the DYRK, which is a dural-specific tyrosine phosphorylation kinase. And through these two small molecules, inhibiting the gene expression of the Wnt pathway, and at the same time blocking the inflammatory pathway and reducing the symptom of osteoarthritis. The third thing we can play around is bone remodeling. Bisphosphonate has been trialed for knee osteoarthritis for quite some years, as yet there is no statistical significance difference compared to placebo. However, the red glycan inhibitor denosumab has been showing some success for hand osteoarthritis, showing a reduction in the X-ray scoring with a very modest pain improvement, however, at a later time point of 2 to 3 years. And finally, don't forget the pain pathway, where the neuron is perceiving the pain signal and send it to the spinal cord and brain. The peripheral pathway is mainly involving the spinal cord, but the pain pathway also extends to the central, the brain, and causing pain sensitization. One of the examples of targeting the pain pathway in osteoarthritis is the use of tanezumab, which is a humanized monoclonal antibody against NGF, nerve growth factor. There have been many randomized control trials showing its capacity in improving pain and function for knee and hip OA. However, it has not been approved so far by authority because of the risk of rapidly progression of osteoarthritis and requiring joint replacement in some patients. And finally, I would like to mention a few novel therapies. The first is targeting cellular senescence. Cellular senescence is a state when the cell cycle is irreversibly arrested. It is thought that oxidative stress from aging or mechanical loading will lead to accumulation of senescence chondrocytes. There have been a few sensiolytic drugs that is undergoing animal study or phase 1 trials. Secondly is the RNA-based therapy. We come to know that the non-coding RNA are actually regulators of inflammation, chondrocyte apoptosis, or extracellular matrix. There are many of these non-coding RNA that has been discovered that target the mesenchymal stem cells, chondrocytes, synovial etc. The main mechanism is targeting the cartilage matrix, including the proteolytic enzyme MMP and ADAMs, or the NF-κB pathway and also inflammatory pathways. With the advances in understanding of the pathogenesis, it seems that we have many targets to go for modifying osteoarthritis. However, there remain a lot of challenges in the development. So far, none of these drugs have been successful in demonstrating structural modification together with symptom improvement. One of the reasons that has been mentioned many times is the heterogeneity and also complexity of the osteoarthritis. Within osteoarthritis, there might be a different phenotype. So it comes to the concept of precision medicine. If you are treating a heterogeneous group of patients with a single drug, there doesn't seem to be a one-size-fits-all if there is a lot of heterogeneity. So if there is a way that can differentiate osteoarthritis into different phenotypes, like inflammatory phenotype, bone phenotype, cartilage phenotype, etc., and give them the appropriate treatment, then we might be demonstrating better response in clinical trials. Now, ladies and gentlemen, I'd like to summarize today. There is currently no DMOC showing capacity to slow down osteoarthritis and has been approved. However, with better understanding of the pathogenesis, there are some new therapeutic targets. I have talked about a few possible molecular pathways that can be blocked to improve osteoarthritis. Firstly, inflammation, like interleukin-1 and TNF blockers. Secondly, blocking the cartilage matrix, You can either do by blocking the degradation, targeting the proteolytic enzyme MMP and ADAMS, or stimulating the regeneration of the cartilage. And thirdly, Wnt pathway. Of course, we can play around with the bone modeling. And also don't forget about the pain pathway. I have also mentioned a few novel therapies, including the sensolytic and RNA-based therapy. However, what we need the most is better idea and ways to phenotype within osteoarthritis, which is a complex disease, such that any kind of therapeutic molecule will be able to show the capacity and efficacy in clinical trials. With this, I thank you very much for your attention.
Katie, thanks for that nice presentation. Can she hear me?
Thank you.
Yeah. There are a lot of gene therapy trials also going on from the literature we reviewed. Is there something on the horizon? There is something in transforming growth factor beta with adenovirus vector and I think an interleukin receptor enter. There is gene therapy.
For gene therapy?
Yeah.
I see. So apology that I am not very aware of any gene therapy that is ongoing for osteoarthritis. Maybe I'm wrong, so perhaps it's a good idea to search around in the clinicaltrial.com.
And do you think the loris equivalent data looks okay and there will be further development of this molecule in the future?
Again, what is the molecule that they are mentioning?
The WNT signaling inhibiting molecule you talked about?
The Wnt pathway, right?
Yeah.
The Wnt pathway, the loricizumab, is now in a phase 3 trial. In a phase 2 trial, it demonstrates that it has a little bit relief in the pain and do have a structural modification response. We hope that it is successful because the field is really dreadful of something that is useful.
There was an ACR abstract on denosumab doing some structural modification in hand osteoarthritis, very recently published. I'm not sure if you came across that and any particular comment on that from your end?
Yes, the one I have included in the talk just now, denosumab is having some good results in hand away. It is not a new thing, it has been for some years. And recently in the ACR abstract, it demonstrates the structural modification response, which is very interesting. However, the pain modification response is quite low to achieve in 48 to 98 weeks. That is something that we need to think about. And there is an ongoing trial for denosumab in knee osteoarthritis. I don't think the result has been released yet. We are looking forward to it.
Thank you.
You know, for example, sometimes osteoporosis, we get a P-score of minus 3.5 or maybe 4.5. That is where denosumab is not going to do anything. You need teriparatide, something that can build up the architecture of the bone also. So in such cases, are we saying that denosumab is particularly good, going to be targeting osteoarthritis, or are we going to be targeting osteoporosis per se? That's what I wanted to say.
I see. So I think there is a current trial on osteoarthritis with denosumab. We are awaiting the results. And for now, but something that I would highlight is that osteoporosis, usually they are slender women, whereas on the other hand, osteoarthritis is affecting people on a little bit on obese side. At the moment, we are not certain without the trial results that whether denosumab is truly effective. Although on the molecular level, you may say that they should have some bone remodeling effect for osteoarthritis.
Thank you.